You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about tricuspid valve disease. We'll start with tricuspid stenosis, then really hone in on tricuspid regurgitation, then finish with carcinoid disease, which can present with both tricuspid regurgitation and stenosis. Native isolated tricuspid stenosis is rare. It almost always presents together with significant TR or MS. Tricuspid stenosis can be rheumatic, congenital, or carcinoid, or there can be an RV inflow obstruction due to a mass such as a tumor or vegetation. Echo parameters for severe TS are as following. Mean gradient using CW Doppler more than 5 millimeters of mercury. Recall this is in comparison to severe MS whose mean gradient was more than 10 millimeters of mercury. And normal gradient in a non-stenotic tricuspid valve is less than 2 millimeters of mercury. Another feature is pressure half-time more than 190 milliseconds, indicating severe TS. Recall this is in comparison to severe MS whose pressure half-time was more than 150 milliseconds. Valve area of 1 or less centimeters squared by the continuity equation. Of course, that assumes that any concomitant TR is mild or less. There will be an associated increase in the right atrial size, just like how severe mitral stenosis will have a concomitant increase in the left atrial size. So severe tricuspid stenosis will have an increased RA size and a dilated IVC. Tricuspid stenosis is rare enough that the 2020 AHA-ACC guidelines on valve disease do not even have a section on recommendations on tricuspid stenosis management, just a section on tricuspid regurgitation management. Let's move on to tricuspid regurgitation. We'll talk about the etiology, then talk about physical exam findings and imaging findings, then talk about medical management, and then intervention. 70% of TR is functional TR, or secondary TR. This refers to TR in situations when a tricuspid valve is anatomically normal. It includes left-sided heart failure, for example, due to mitral regurgitation or aortic stenosis, leading to increased right heart pressures, pulmonary hypertension from any cause such as COPD, ILD, or PE, RV dysfunction, for example, from ischemic heart disease or right-sided heart failure. 20% of all TR is primary TR, which refers to TR from anatomically abnormal tricuspid valves. For example, infective endocarditis, especially in intravenous drug users. This makes up 2% of all TR. Carcinoid heart disease due to serotonin-induced plaque formation on the valve leaflets. Rheumatic heart disease, although rheumatic involvement of the tricuspid valve is rare compared to the mitral and aortic valves. Congenital anomalies such as Ebstein's anomaly, a malformation of the tricuspid valve with the downward displacement of the leaflets. Trauma, including pacemaker and defibrillator leads causing leaflet damage. And myxomatous degeneration or redundancy of leaflets. Those are examples of primary TR, which are TR from anatomically abnormal tricuspid valves, making up 20% of all TR. 5% of all TR is isolated annular dilation, and this is often grouped under functional TR, which is TR in situations when the tricuspid valve is anatomically normal. Chronic atrial fibrillation leads to annular dilation due to right atrial enlargement. Dilation of the tricuspid annulus can lead to regurgitation without RV dilation or pulmonary hypertension. 5% of all TR is pacemaker or ICD lead-induced TR, and is often grouped under primary TR. Pacemaker or defibrillator leads can cause mechanical interference with the tricuspid valve, leading to leaflet tethering, perforation, or annular distortion, resulting in TR. A few details in assessing the etiology. If echo shows no tricuspid valve leaflet thickening, that excludes carcinoid and rheumatic disease. Rheumatic tricuspid disease would have diffuse leaflet thickening with restriction of opening due to commisural fusion, chordal shortening, and calcification with characteristic diastolic doming. Carcinoid disease would have short, thick tricuspid leaflets with systolic and diastolic restriction. Ebstein's anomaly would have apical displacement of the tricuspid valve septal and posterior leaflets from the atrioventricular ring. Echo would show that the septal and posterior leaflets are adherent to the underlying myocardium with an apical displacement of at least 8 mm per meter square compared to the mitral valve annulus. Endocardial pacemaker leads can cause inflammation and fibrosis, leading to entrapment of the lead. The TR that results from endocardial pacemaker leads will exhibit an eccentric rather than central trajectory, with the septal leaflet being the most common leaflet to be entrapped. If there is prominent leaflet tethering, it is almost always CIED-related TR, which is ICD or pacemaker-related tricuspid regurgitation. CIED-related TR makes up at least 5% of TR, as I mentioned earlier. Patients with pulmonary hypertension-related TR will have a dilated RV, but a normal tricuspid annulus size. In contrast, patients with non-pulmonary hypertension-related TR will tend to have a normal RV size, but a dilated tricuspid annulus. Moving on to physical exam and imaging findings. Tricuspid regurgitation can have a huge V wave on JVP, a systolic murmur at the lower sternal border that increases in intensity with inspiration, and a pulsatile liver edge. But in many TR patients, the elevated V wave is the only physical exam clue to the presence of advanced TR, because a murmur may be inaudible even with a severe TR. On central venous pressure waveform, in TR, you will see a very tall V wave and the C and V peaks have merged. The X descent is not discernible. This produces a wide positive and tall V wave called the CV wave. This occurs because the TR jet increases the RA pressure, so the phase of RA relaxation is not accompanied by the usual reduction in RA pressure, causing the X descent to vanish. Other than TR, this pattern of tall V waves with a single merged CV with the absence of X descent is also seen in ASD. In extreme cases, you can have a single wave with ACV all merged. The C wave and X wave are obscured as the A, C, and V are merged in a single wave. This tends to occur when heart rate is tachycardic above 120 beats per minute, such as in acute tricuspid regurgitation. On echo, the IVC would be plethoric, not collapsed in severe TR. Systolic notching of the pulmonic valve is a sign seen in severe pulmonary hypertension that would not occur in primary TR. Peak TR velocity only reflects the RV-RA pressure gradient and has nothing to do with the severity of TR. 70% of cases of significant TR are functional and related to tricuspid annular dilation and leaflet tethering in a setting of RV remodeling due to pressure and/or volume overload, as I mentioned at the start. Because severe TR has equalization of RA and RV pressures, the RV systolic pressure will be underestimated if you try to do it the normal way using 4 times the tricuspid velocity squared. The assessment of pulmonary artery pressures can be quite challenging in a setting of torrential tricuspid regurgitation, with the typical calculations prone to be underestimated. The right atrial pressure is often much higher than 20 milliliters of mercury, and hence the echo estimation of RA pressure is usually a significant underestimation. Furthermore, RA pressure becomes ventricularized, and a simplified Bernoulli equation is no longer suitable for use as the proximal velocity is no longer much lower than the distal velocity. Doppler interrogation of the right ventricular outflow tract is required to ensure there is no obstruction to flow, such as pulmonary valve stenosis. The assumption that the estimated RV systolic pressure equals the pulmonary artery systolic pressure only holds true if there is no RV outflow tract obstruction. Enlarged tricuspid annulus is when the diameter is more than 40 millimeters or more than 21 millimeters per meter square. Severity of TR has independent mortality risk independent of RV dysfunction, RV systolic pressure, AFib, LV ejection fraction, and mitral regurgitation. Even the post-operative mortality is high. TR is highly load dependent, so it varies based on diuresis and afterload. TR is respiraphasic, so you should get VTI average over at least 3 beats. Now let's talk about quantifying TR severity. Qualitative features of severe TR are seeing a large central jet on color Doppler or a dense triangular CW Doppler envelope. Semiquantitative features of severe TR are jet area more than 10 centimeters square, vena contracta of at least 0.7 centimeters, a PSI radius more than 0.9 centimeters, and systolic flow reversal in a hepatic vein. Structural features of severe TR are flail leaflet, severe tethering or coaptation gap, or leaflet perforation. Quantitative features of severe TR are EROA of at least 0.40 centimeters square, or regurgitant volume of at least 45 milliliters. Recall that EROA, or the effective regurgitant orifice area, is flow divided by peak velocity. In TR, assuming there is no severe pulmonary hypertension, peak velocity is a lot lower for a given TR severity compared to MR. And so for the same PSI radius, the EROA will be much higher. Recall, regurgitant volume is EROA times VTI. In TR, VTI is a lot lower than in MR, so your regurgitant volume will be much smaller in TR. Now let's go over medical management. If they have signs or symptoms of right-sided heart failure, such as lower extremity edema or ascites, loop diuretics are first line to relieve systemic congestion, although it may worsen low flow syndrome. MRAs may add benefit to loop diuretics, especially if there's hepatic congestion, which may promote secondary hyperaldosteronism. Low salt diet and compression stockings may be helpful. If LV ejection fraction is reduced, HFrEF GDMT should be given. If pulmonary hypertension is present, reduction of pulmonary artery pressures and pulmonary vascular resistance with specific pulmonary vasomodulators may be helpful to reduce RV afterload. If TR is secondary to annular dilation associated with AFib, AFib should be managed. Let's consolidate our knowledge on the medical management of TR using the wording from the HAAC 2020 guidelines on the management of patients with valvular heart disease. In patients with signs and symptoms of right-sided heart failure attributable to severe TR, stages C and D, diuretics can be useful, class 2A. In patients with signs and symptoms of right-sided heart failure attributable to severe secondary TR, stages C and D, therapies to treat the primary cause of heart failure, for example, pulmonary vasodilators to reduce the elevated pulmonary artery pressures, GDMT of heart failure with reduced LVEF or rhythm control for AFib can be useful, class 2A. How about intervention? In patients with symptomatic severe primary tricuspid regurgitation, tricuspid valve surgery can alleviate systemic venous and hepatic congestion and decrease reliance on diuretics. In patients with severe congestive hepatopathy, tricuspid valve surgery can prevent irreversible liver cirrhosis. In patients with severe symptomatic primary tricuspid regurgitation from ICD or pacemaker lead or RV biopsy, TR develops rapidly, and surgery can be done before the onset of RV dysfunction. Mortality rates have historically been high for isolated tricuspid valve surgery since it was usually done in late stages of disease when patients became symptomatic with right heart failure signs and symptoms, and even more so if it was after prior left-sided valve surgery. Now, if a reoperation is needed for isolated tricuspid valve surgery, we try to do it before the onset of severe RV dysfunction, severe PH or hepatic or renal dysfunction. If there are no comorbidities, for example, isolated severe primary tricuspid regurgitation due to trauma, tricuspid valve surgery has a less than 1% operative mortality rate in the absence of RV dysfunction or pulmonary hypertension. The severity of TR may fluctuate with time depending on the preload and pulmonary pressures. Therefore, any history of prior right heart failure signs and symptoms is considered alongside tricuspid annular dilation as a risk factor for progression to TR and indication for concomitant tricuspid valve repair. AFib-related TR is pathophysiologically different from other types of secondary TR, with greater basal dilation and annular enlargement, whereas secondary TR from pulmonary hypertension or myocardial disease tends to have RV elongation with leaflet tethering. AFib-related TR has rapid progression of TR severity and right-sided chamber dilation, so these patients should get tricuspid valve surgery. Irrespective of whether severe TR is primary or secondary, it is not guaranteed to improve after intervention on a left-sided valve lesion and reduction of RV afterload. Moreover, reoperation for isolated tricuspid regurgitation after initial left-sided valve surgery has a high perioperative mortality rate of 10 to 25%. Therefore, if left-sided valve surgery is being done, the severe TR should also undergo surgery at the same time. It does not appreciably augment the risk of left-sided valve surgery. It is possible for moderate TR to get surgery if certain conditions are present at the time of consideration for left-sided valve surgery. If left uncorrected at the time of left-sided valve surgery, mild or moderate secondary TR will progress to severe in 1/4 of patients. Risk factors for progression of TR are tricuspid valve dilation more than 40 millimeters in diameter or more than 21 millimeters per meter square indexed, degree of RV dysfunction, leaflet tethering height, pulmonary hypertension, AFib, and intraannular right ventricular pacemaker or ICD leads. So, in moderate TR, if there is annular dilation more than 4 centimeters in diameter or right-sided heart failure signs or symptoms, these are the non-severe TR patients that you should consider for concomitant TR repair during their left-sided valve surgery. It remains unclear what the optimal timing for tricuspid valve surgery is for severe primary TR patients who are asymptomatic or minimally symptomatic, so they say it can be considered if there is progressive RV dilation or systolic dysfunction. The recommendation is weak 2B because it is extrapolated from limited experience. What are the specific guidelines regarding timing of intervention for TR from the 2020 AHA-ACC valve disease guidelines? They say, in patients with signs and symptoms of right-sided heart failure and severe isolated secondary TR attributable to annular dilation in the absence of pulmonary hypertension or left-sided heart disease, who are poorly responsive to medical therapy, that's valve disease stage D, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalizations. That's a Class 2A recommendation. In patients with signs and symptoms of right-sided heart failure and severe primary TR, stage D, isolated tricuspid valve surgery can be beneficial to reduce symptoms and recurrent hospitalizations, Class 2A. In patients with severe TR, stages C and D, undergoing left-sided valve surgery, tricuspid valve surgery is recommended, Class 1. In patients with progressive TR, stage B, undergoing left-sided valve surgery, tricuspid valve surgery can be beneficial in the context of either tricuspid annular dilation, that is tricuspid annulus and diastolic diameter more than 4 centimeters, or prior signs and symptoms of right-sided heart failure, Class 2A. Lastly, they say in patients with signs and symptoms of right-sided heart failure and severe TR, stage D, who have undergone previous left-sided valve surgery, reoperation with isolated tricuspid valve surgery may be considered in the absence of severe pulmonary hypertension or severe RV systolic dysfunction, Class 2B. What about asymptomatic patients? Can they get surgery for severe TR? According to the 2020 valve disease guidelines, in asymptomatic patients with severe primary TR and progressive RV dilation or RV systolic dysfunction, isolated tricuspid valve surgery may be considered with a Class 2B recommendation. So to summarize all of that of when to intervene on TR, the only Class 1 indication is severe TR at the time of left-sided valve surgery. For Class 2A recommendations, you have progressive TR with dilated annulus and right heart failure or right heart dilation, and severe symptomatic TR. For secondary TR, you need to make sure that there is no pulmonary hypertension and no left heart disease. Then the Class 2B indications for primary TR is asymptomatic severe TR with progressive RV dysfunction. For secondary TR, the Class 2B indication is symptomatic severe TR in the setting of prior left-sided valve surgery. Now we'll go over carcinoid disease. Carcinoid is a slow-growing neuroendocrine malignancy that leads to focal or diffuse deposits of fibrous tissue in the endocardium of the valvular cusp. Carcinoid tumors secrete up to 40 products, including serotonin, histamine, vasoactive intestinal peptide, that are normally metabolized by the liver and normally cause minimal symptoms. However, when GI carcinoid tumors metastasize to the liver, they prevent and bypass hepatic inactivation of the above products, resulting in systemic manifestations, which we see as carcinoid syndrome. Carcinoid tumors are characterized by nocturnal diarrhea, flushing, weight loss, fatigue, and episodes of tachycardia. 40% of carcinoid syndrome has valvular heart disease, which is almost always right-sided valvular disease. As mentioned just now, only carcinoid patients with liver metastases will develop the distinctive right-sided valve lesions. In 15% of carcinoid heart cases, there's also involvement of left-sided valves, and that would raise the likelihood of concomitant patent foramen ovale, bronchial carcinoid tumor, or simply high levels of circulating vasoactive substances. In carcinoid disease, the tricuspid valve becomes characteristically immobilized in a partially open position, resulting in severe TR with simultaneous tricuspid stenosis. This is in contrast to rheumatic tricuspid stenosis, which would have doming of the tips of the tricuspid leaflets and subvalvular thickening. The tricuspid valve with or without pulmonary valve involvement is affected in most cases of carcinoid heart disease. The RV typically enlarges, becomes overloaded, develops paradoxical septal motion, but RV function manages to remain intact until later in the disease course. Historically, mechanical prostheses were favored over bioprosthetic valves in carcinoid patients due to a theoretical concern for bioprosthetic valve degeneration from vasoactive substances. But improvements in somatostatin analogs have made this no longer a concern. Additionally, given that carcinoid patients develop multiple liver metastases and will have future coagulopathies, bioprosthetic valves are now favored over mechanical valves. Use of bioprosthetic valves also makes subsequent tumor resections not require the need for full anticoagulation. Surgery can precipitate carcinoid crisis, which is hypotension, bronchospasm, and flushing, so you have to give perioperative octreotide starting 2 hours before surgery and continuing 48 hours after surgery, followed by transition to subcutaneous octreotide. That's all for tricuspid regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.